Hello friends. So today I'll be talking on ABG analysis as a part of trainee tutorials. So it's a very basic talk on approach to arterial blood gas and the way to interpret the arterial blood gas in your daily practice. So there are various ways that one could interpret ABGs. Just uh, would be picking up the things that are more common and more commonly used and possibly more easy to remember as well. So when we talk about arterial blood gas, so basically when we look at ABG, there are different variables that you would see in an ABG. And basically, in essence, what it reflects is how well the patient is oxygenated, how well he's breathing, which is indicated by his ventilation, which is obviously the amount of oxygen and CO2 that it would show. And most importantly, the acid base measurements and what it means. So as you see, and the PaO2 that you would measure would also factor in its relation to the FiO2 that the patient would be getting, and the PaO2 FiO2 ratio, which is very important for us to determine how severe is the respiratory failure and whether it is a mild ARDS, moderate ARDS, or severe ARDS. So this is pretty much what you can make out. And nowadays, any ABG would show you even electrolytes. So because it gives you electrolytes and bicarbonate, so you are expected to interpret the acid base and the anion gap and the type of acidosis and the gap and the correction of anion gap. So these are the some of the variables that you could derive from whatever you see in the ABG. So basically, when you have first thing you would see in an ABG, you would see pH, then you would see oxygen. We'll first talk about the oxygenation and ventilation. So when you have a low PaO2 in an ABG, then there are clearly two broad categories that one needs to know as to what may be causing the hypoxemia. So one is that patient is not ventilating well, he's not breathing well. So there is a reduced ventilation. So obviously he's not taking enough ventilation, his minute ventilation is low, then his oxygenation would be low. So there you would get the key thing that we look is AA gradient, alveolar arterial oxygen gradient. So why we do this AA gradient is to determine whether the problem is with patient's ventilation or whether there is problem at the gas exchange at the alveolar level. So that is determined by AA gap. So when patient is not breathing well, which means the lung is structurally okay, alveolar function is okay. So their alveolar arterial gradient will be normal. So, but suppose if you have a problem like this, so this is a very important physiological unit of your oxygenation, where basically you would have carboxyhemoglobin that comes from your pulmonary circulation, and then carbon dioxide is released here, so carbon dioxide goes out, and the free hemoglobin is meant to bind to oxygen and enters the pulmonary venous circulation. So this is the normal unit of ventilation within the lung. So if you have a problem where your hemoglobin is unable to bind to the oxygen, so oxyhemoglobin is not formed because of oxygen not reaching the alveoli for whatever reason, it may be asthma, COPD, or anything, then you would have hypoxemia. Or you have a problem where hemoglobin is bound to oxygen but is unable to be circulated because of whatever microthrombi. So this we call it as ventilation perfusion mismatch. So basically there is ventilation happening but perfusion may not be happening. Or perfusion is happening, ventilation may not be happening. So this is a very important concept you need to understand, which we call as ventilation perfusion mismatch. In this situation, you will have a AA gap which will be abnormal, which will be high. So, or you have a shunt mechanism. So, the commonest cause of respiratory failure in any critical annual will be either of these, predominantly the shunt. Shunt is where your whole alveoli is not participating in the gas exchange because of problems in the alveoli, which means the alveoli may be flooded with inflammatory exudate like ARDS, or it may have pneumonia, or it can have pulmonary edema, or it can have aspiration. So where alveoli is abnormal and it is not participating in the ventilation. So that's a shunt mechanism. So these are the situation where you'll have a high AA gradient or alveolar arterial oxygen gradient. So that's why it's very important to determine AA gap to understand whether the problem lies with ventilation or the problem is with the structural units in the lung which participate in ventilation. So either it's ventilation perfusion mismatch or the shunt mechanism. So that is the key concept of understanding the AA gradient. So for alveolar oxygen, so you need to, it is dependent on certain variables to determine alveolar oxygen. So many of the anesthesiologists who would be listening to me, they would be fairly well versed in understanding how to calculate the alveolar oxygen. So that is dependent on hemoglobin and saturation, and you need to determine the oxygen content of the blood. So oxygen content is calculated with this formula, saturation into hemoglobin into 1.34, and your alveolar oxygen is calculated with this formula, where FiO2 is multiplied into atmospheric pressure minus hydrostatic pressure. So this is at the sea level, it's 47. So PaCO2 divided by 0.8. So at sea level, if you are dealing with this equation at the sea level, then your PaO2 is just simply 150 minus PaCO2 by 0.8. So with this you will get an alveolar oxygen. Then PaO2 is determined by your blood gas, you minus. So your AA gradient should be ideally not be present, it should be 0, or it may be up to maybe 10, but beyond that, if it is there, then you know there is problem at the ventilation at the alveolar level. Either it can be VP mismatch or it could be shunt mechanism, which is leading to high AA gradient. Okay, so that is our understanding. And this you would understand by this oxyhemoglobin curve. So I'm sure all the anesthesiologists or all the basic trainees, you would be very well versed with this oxyhemoglobin curve. So the why we are so much interested in this curve is because, as you see, so this is the saturation, this is the PaO2. So there is a critical threshold at which a small drop in the PO2 will lead to rapid fall in the saturation. So that threshold is what is very important. So at about PaO2 of 50, the saturation, so they have algorithmically looked at different PaO2 and what is the saturation. So at PaO2 of 50, the saturation is around 88%. So even a small drop from here of PaO2 will see a rapid fall in this saturation. I think that is what we need to very clearly understand in critically ill as to why we try to maintain saturation above 92, because any saturation that falls less than that, there will be a rapid decompensation and deterioration of the patient. So that's why our whole science of intensive care is to focus on maintaining saturation at least above 90 or 92, so that you don't want to get it below 88 where there will be a rapid fall in saturation. So this is a tabular format. So at PaO2 of 99.7, you have a saturation which is 100% always. A small drop at this level, PaO2 from 99 to even 60, so there will be little or no effect on the arterial saturation. That's why you see that curve. But at 50, 88. But after that, even a small drop in PaO2 from 50, there will be a big drop in the arterial saturation. And at around 26.25 of PaO2, your saturation would be around 50%. So this is a tabular sort of representation as to the correlation between saturation and PaO2. And so you need to understand certain reasons for this oxyhemoglobin curve which moves to the left. So it's very simple to remember, and these are typically asked in most of the entrance exams. So oxyhemoglobin moving to the left is all decreased temperature, decreased 2,3 dpg, decreased hydrogen or carbon monoxide poisoning. Shift to the right is all increased temperature, increased 2,3 dpg or increased hydrogen. So this is the typical sort of a reasons for the oxyhemoglobin curve to shift to the left or to the right. So that is in essence about the importance of PaO2 and the factors that influence the alveolar oxygen gradient. Okay. So now we look into stepwise approach to diagnosing ventilation and acid base. So there is a process, there are multiple approaches. So what I'm going to talk is the 6-step approach by Narins and Met. So when you look at ABG, obviously we look at pH, we look at CO2, then we look at bicarbonate, and we look at oxygen. So oxygen we have already spoken. So the first step in ABG interpretation is to look at the pH, whether there is acidemia or alkalemia. For that, we all need to know what is the normal pH. The normal pH that is shown on the ABG will be 7.38 to 7.42. So acidemia is when pH is less than 7.38. Alkalemia is when pH is more than 7.42. See, here the nomenclature is little important. we use acidemia. When we say acidemia, you're only looking at pH and telling whether it is acid or alkali, whether it's moving towards, we call it acidemia. When we say acidosis, then you're talking about the mechanism that is involved, whether it is respiratory mechanism or metabolic mechanism involved leading to acidemia. That's when we call metabolic acidosis, respiratory acidosis. If you're only looking at pH, we only call it as acidemia or alkalemia. Okay, so that is the first step. You look at pH and say whether it's acidemia or alkalemia. Then we need to understand, so the pH is defined as negative logarithm of hydrogen ions. What it means is, for a pH of 7.4, the cumulative hydrogen ions that are needed is 40. As you see, as the pH decreases, hydrogen ion increases. That's why we call it as negative log of hydrogen ions. Or if pH increases, your hydrogen ions decreases. So that is the concept of pH. So for the pH to increase, your hydrogen ions has to come down. For pH to come down, your hydrogen ions has to go up. So this concept is also something that you should understand, what may be leading to acidemia or alkalemia. So the step 2 is to determine whether that acidemia or alkalemia is due to metabolic cause or respiratory cause. So when it is a respiratory cause, then you would say, so you would obviously look at CO2. So if the CO2 is more than 42, then we call it as respiratory acidosis, which means respiratory variable is what is influencing the acidemia component of pH. If pH is less than 38 millimeter mercury, we call it as respiratory alkalosis, because you know alkalemia is less than 7.38. So same thing applies for metabolic. So normal bicarbonate is 22 to 26. If you see in ABG, pH is say 7.46, which is alkalosis. Then you see the bicarbonate more than 26, you call it as metabolic alkalosis. If bicarb is less than 22, you would call it as metabolic acidosis. So when you say acidosis or alkalosis, it means you are determining the cause, whether it is respiratory cause or metabolic, and then for that you have to look at CO2 or you have to look at bicarbonate. So these two become very important entities to say acidosis or alkalosis. Otherwise, only at pH you can only say it's alkalemia or acidemia. Okay. So this is a very important table which I'm sure many of you advanced trainees would know very well. So when there is a metabolic acidosis or alkalosis, all arrows move in the same direction. That is the typical conventional narrative that we give. So when metabolic acidosis, pH comes down, bicarbonate comes down, and the compensation is determined by blue thing. CO2 also comes down. That's a compensation, because CO2 has to come down to compensate for the bicarbonate that is come down. So basically these are straightforward compensation. All arrows move in the same direction. So if metabolic alkalosis, pH goes up, bicarbonate goes up. So your compensation, all compensations are in blue. So CO2 also goes up. So that is the uh, body's response to compensate for the abnormality that is happening. Then you have respiratory acidosis. So this is, as you see, you know, here your pH comes down, but your bicarbonate goes up in relation to CO2. So metabolic, all arrows go in the same direction, but in respiratory it is a little different. So pH comes down, so your bicarbonate goes up as a compensation for the CO2 that is going up. So respiratory alkalosis, pH obviously goes up, so CO2 comes down and the bicarb. So if you see the compensation arrows, all compensation arrows are in the same direction. See here CO2 comes down, bicarbonate comes down. CO2 goes up, bicarbonate goes up. Here CO2 goes up, bicarbonate goes up, CO2 comes down. So all the compensation happens in the same direction. Okay, so this is a very important table and it is fairly intuitive that bicarbonate comes down, carbon dioxide has to come down as a compensation. Bicarbonate goes up, carbon dioxide goes up. Even in respiratory acidosis, CO2 goes up, bicarbonate has to go up, CO2 comes down, bicarbonate has to go down. So this is something which you have to imprint in your mind, that arrows moves in the same direction, right, as compensation. Okay. So that is the step 2, where you determine which is contributing to the acidosis or acidemia. So step 3 is we look into the respiratory disorders. So respiratory disorders can be acute or chronic. Okay, so in acute there is acute respiratory acidosis or acute respiratory. See, metabolic uh, Mainly this acute and chronic applies in respiratory. So there is acute, that is the step 3 to look at the respiratory disorder. Chronic, there is again chronic respiratory acidosis, chronic respiratory. So in acute respiratory, so when there is acute, pH acutely changes, but the compensation is limited because body doesn't have time to respond and compensate in that short period of time. That's why when the pH, suppose a respiratory acidosis, pH comes down. So which means CO2 has gone up. Bicarbonate has gone up, should go up, but there may not be much time for the bicarbonate to reach that level in acute. That's why in like cardiac arrest situation or acute deterioration with respiratory failure, you would not see bicarbonate instantly going up. So that is an indicator that it's an acute phenomenon. And same thing applies in acute respiratory alkalosis. So step 3 is to determine whether it is acute or chronic. You would know it is chronic when bicarbonate has gone up to compensate for the acute rise in the CO2. But that would not happen. See, chronic also you have chronic respiratory acidosis, chronic respiratory alkalosis. So in chronic respiratory acidosis, obviously your bicarbonate would have gone up because body has enough time for the bicarbonate to be reabsorbed from the tubules and it will reflect with a high bicarbonate. And same in chronic respiratory alkalosis, bicarb would have eliminated from the body. So body would indicate to you that bicarbonate levels are low because there would have been time for the bicarbonate to have been eliminated. So step 3 is to determine whether it's acute or chronic. So step 4 is also very important. So that is step 3 is respiratory, acute chronic. Step 4 is you have metabolic acidosis to determine whether you have an anion gap or whether it is a no anion gap or normal anion gap. I like to call it as normal anion gap and high anion gap. So anion gap is simply the difference between measured cations and measured anions, which is sodium plus potassium minus chloride plus bicarbonate. Some people leave the potassium out. So the major cations are all the positively charged: sodium, calcium, potassium, magnesium. So the major cation is mainly sodium. So that's why sometimes we take potassium or you can ignore potassium. The anions are all the negatively charged: chloride, bicarbonate, proteins, organic acid, phosphate. But the major ones are chloride, bicarb. That's why we take chloride and bicarbonate. So normal anion gap is 8 to 12 milliequivalents per liter. So if there is increased anion gap, it means there is accumulation of acids. So that is something which we should understand and determine what is the cause of this acid accumulation. Okay. So low albumin is generally present in around 75% of our critically ill patients. So if you have a low albumin and you measure an anion, so anion may be high, but it will show it as, it will underestimate the anion gap. That's why we have to do a correction for low albumin. That's what we call it as corrected anion gap. So the corrected anion gap is simply you have to correct for the low albumin. If suppose you have a patient with albumin of 1.5 in ICU and your anion gap is 12, but it may be showing low, but if you do the corrected one, it will show the exact anion gap, which may be high. So corrected anion gap is something you do when the albumin level is low. So it is calculated by the anion gap that you have measured, 12, if it is 12, plus 0.25 into normal albumin minus observed albumin. So this will correct for the underestimation that it is shown by low albumin. Okay, so this is the formula. You can remember or you can Google whenever you have a patient with low albumin. You need to at least think there is a formula to correct for the anion gap. Okay. So if pH is more than 7.5, the anion gap can be high because albumin surface is more negative. So you can possibly just ignore that. So the step 5, this is also important to look at the gap. So this is a very important step for at least all ICU trainees. So when you have a high anion gap metabolic acidosis, we need to see whether there is a coexisting other abnormality that may be present or other coexisting acids that may be contributing to the high anion gap. So for this, the assumptions we make is for 1 milliequivalent raise in the anion gap, so your expectation is there should be 1 milliequivalent reduction in bicarbonate as a compensatory mechanism. So which simply means change in anion gap should be equal to change in bicarbonate. Okay, so that is the hypothesis that we create. And so in metabolic acidosis, So metabolic acidosis, obviously you have dealing with a high anion gap metabolic acidosis. So when there is 1 milliequivalent rise in anion gap, there should be more than 1 milliequivalent fall in bicarbonate as per the above equation, which means the delta anion gap should be less than delta bicarbonate. Okay. So same thing applies in metabolic alkalosis. Metabolic alkalosis, this is we are talking about high anion gap, where anion gap anyway goes up. So 1 milliequivalent raise in anion gap should be equating to less than 1 milliequivalent fall in bicarbonate. So change in anion gap should be greater than change in bicarbonate. So this should happen in metabolic alkalosis. So based on this, we derive on this one gap. So this, if you remember this slide, forget about the previous slide. If you remember, that is the previous slide is a concept to this current sort of a derivations that we have accepted as gap. So you look at change in anion gap. So if it is suppose patient's anion gap is say 16 and normal anion gap is 8 to 12. So 16 minus 8 or 16 minus 10. So 6. And then you have to look at change in bicarbonate. Suppose the bicarbonate in the ABG is showing say 16. Then you divide 22 minus 16, that is the change in delta bicarbonate. If it is less than 1, it means there is a high anion gap metabolic acidosis. Along with it, there is a normal anion gap metabolic acidosis. So there is a two problems that are coexisting, that we call it as a gap. Okay. So this is an example. So if your measured anion gap is say 16, I'm just giving an example, and that is your normal anion gap. So bicarbonate you take 24 as your normal bicarb. Measured is what your patient's ABG is showing. If measured is say 16, you do that. If this is less than 1, then there is a coexisting normal anion gap metabolic acidosis. The common cause is hyperchloremic metabolic acidosis. So this is the gap phenomena that we need to ascertain in any patients which have high anion gap acidosis. Or if you say change in anion gap divided by change in bicarbonate, if it gets, you only have to see whether it's less than 1 or more than 1. If it is less than 1, you have high anion metabolic with normal anion gap. If it is more than 1, you have high anion gap with metabolic alkalosis, and the causes are furosemide and nasogastric aspiration and other things. So this is all is a gap. Basically what all the trainees should remember is you have to look at change in anion gap divided by change in bicarbonate. You should only remember two numbers, less than 1 or more than 1. Less than 1, there is a coexisting normal anion gap. If it is more than 1, there is a coexisting metabolic alkalosis. That's all if you have to remember. So if you understand this, you will be able to interpret any ABG whether there is a coexisting problem along with the high anion metabolic acidosis. Hopefully it's clear. You can rehear to this lecture if you have to recall this. So I only request that you remember this change delta anion gap divided by delta bicarbonate less than 1 and more than 1. Less than 1, no, there is a normal anion gap along with high anion gap. More than 1, there is metabolic alkalosis with high anion gap. So that's all it is. Because I see many trainees getting terribly confused when gap when we ask in exams, and they go all over the place. So this is all it is to the whole thing. Okay. And obviously we ask about causes of anion gap acidosis, high anion gap acidosis. I'm sure many acronyms are there. So Mudpilers is one of the acronym I'm sure many trainees would have heard. I think this is an easy acronym for you to remember the causes of high anion gap acidosis. So M stands for methanol. So I've just put in a pictorial format. If you remember this picture, I think that should be good enough. U is uremia, high urea. So D is DKA and P is paraldehyde. Paraldehyde may not happen very commonly in India. And I is INH tablets or any other medicines. L is lactic acidosis. E is ethanol. R is rhabdomyolysis and S is salicylates. So these are the ready reckoner causes for your high anion gap acidosis. Then there are similar causes for non-gap or normal anion gap metabolic acidosis. So the acronym for that is Durham. So if you can remember. So when you have a patient with non-gap acidosis or normal anion gap, then it is important you understand this concept of urine anion gap. So you check urine anion gap is similar to the blood anion gap. You basically do look at the difference between urine sodium plus potassium minus urine chloride. So this is also very important. If urine anion gap is negative, then the loss of bicarbonate is in the bowels. Negative, N-E-G-U-T, gut. You remember that, negative. So if urine anion gap is positive, positive means more than 0, then you are losing it through the kidneys, renal tubules. So if it is less than 1, you have written negative, gut is there, it is not GI cause. GI cause of loss of bicarbonate. So if it is positive or more than 0, then you call it is the loss of bicarbonate in the kidneys. So the causes for that, easy to remember, is Durham. So D stands for diarrhea because you are losing bicarbonate in the intestines. It can be diarrhea, or it can be colostomies, or it can be fistulas, and all the ureteric diversions that you would have done. Any ureteric diversion surgeries, ureters connected to the bowels, all those surgeries can cause normal anion gap acidosis. Basically, there is loss of bicarbonate either through urine or kidney. So through kidney, RTA, renal tubular acidosis, and these are all a common entrance question, type 1 and type 4. They are the cause for normal anion gap. And H stands for hyperalimentation, where patient is on artificial feeding or nasogastric aspiration, or there is a HCl ingestion. And A is acetazolamide. Acetazolamide causes bicarbonaturria. It eliminates bicarbonate in the urine. So if someone is in diamox for any reason, that can lead to normal anion gap acidosis. And miscellaneous, there is some toluene poisoning and post hypocapnia and some cholestyramine injection. So these are the typical textbook causes for normal anion gap, and mud flyers is the causes for high anion gap acidosis. So that's all it is to the acidosis. And step 6 is to look at the compensations, metabolic and respiratory compensation. So all the trainees in exam, we do ask what is the metabolic compensation, metabolic acidosis, respiratory acidosis. So these are formulas. So there are many formulas. So this is the formulas I follow. So I put up the formulas which I think is easy to remember. For metabolic acidosis, we use Winter's formula. So what happens to metabolic acidosis? Bicarbonate comes down, so your CO2 has to come down. So the expected CO2 you calculate with this formula, 8 plus 1.5 into bicarbonate plus 1 minus 2. I'm sure most of the trainees will be aware of this Winter's formula. So if it is metabolic alkalosis, what happens to bicarbonate goes up, CO2 also should go up. So the expected CO2 you calculate with 20 plus 0.7 into bicarbonate. But CO2 should not exceed more than 50 to 55. So these formulas, I don't know how you'll remember, but you may have to just keep it in mind, memorize, so that in exams you have a fairly good concept of looking at compensation. So respiratory acidosis, CO2 goes up, so your bicarbonate goes up. So there are two formulas in respiratory. For acute, the change in bicarbonate should be equal to change in CO2 divided by 10. So basically what it means is, so if suppose CO2 is gone up to say 60, right? So you have to look at 60 minus, you take 40 as normal or 45, 60 minus 45 divided by 10. So that would be 60, okay, 20 by 10 if you take, so it will be 2. So if bicarbonate you take it as 24, so you should add 2, 26. That is in acute. Chronic you have to do multiply by 3 or 3 to 3.5. So 3 into 2 is 6. So you have to add 6. If bicarbonate is 24, so 6 plus 4, 30. So your compensation should be around 30. You got it? So that is how we calculate. That's why you look at the delta here. Okay. Same thing for so the only numbers for acidosis, you remember 1 and 3. For acute, it is change in bicarb divided by 10. 3 into change in bicarb by 10. For alkalosis, remember 2 and 5. 2 into change in CO2 by 10. 5 into change in CO2 by 10. So for acidosis 1 and 3, for alkalosis you have to remember 2 and 5. Okay, so we can do this in examples, but you have to remember this to understand the compensation. So if you don't like this formula, these are formulas I tend to remember and I apply, but these are different formulas. So you can choose whichever you wish to and you can apply for compensation. Okay, so that is about step 6, sorry. So that's about it on ABG. So I'll give you an example. So this is how you interpret an ABG. So I'm only going to give one or two because this is not a practical session. So 33 male patient with SARS has a saturation of 91 on FiO2. So any saturation will look into the context of FiO2. Is he hypoxic? Is there an acid base? So your PaO2 is 60.75, PCO2 is 35. So here you need to see whether it's hypoventilation or due to alveolar. Common sense tells us there is an alveolar issue, there may be a shunt because he has a SARS virus. But if you are asked to calculate alveolar oxygen gradient, so you calculate using the formula and you get a huge AA gradient. So you know there is possibly a shunt mechanism or a VP mismatch. So this is just one example I'm showing. 50-year-old male with septic shock. So pH is 7.15, CO2 is 30, PO2. So here you know pH is acidemia. So the one that is leading to is bicarbonate. So it is metabolic acidosis, isn't it? So obviously you would look at Winter's formula. So 8 plus 1.5 into bicarbonate plus or minus 2. So your expected CO2 is 23.45, but here CO2 is 30. So you would call it as metabolic acidosis plus respiratory, because if you have to say compensated metabolic acidosis, CO2 should have been 23. Because it is high, you call it as metabolic acidosis plus respiratory acidosis. So I've just given one example. So generally what we do is we give this lecture and we take you through the stations in practical session and give you a lot of ABG examples and get you to solve them. So you can rehear to this lecture about the stepwise. So there are 6 steps, go stepwise. So you will be able to interpret any ABG in the right spirit. Okay. So thank you very much. I'll just take you from historical bit. So this is the Claude Bernard. So you know I'm a medical philatelist. So this stamp was issued in 1990. So he was the first one who determined oxygen in the blood in the year 1858. Okay. And Oscar Minskowski, he was a Lithuanian. So he was the first one to determine carbon dioxide in blood of a patient with diabetic acidosis by gasometric method. So these pioneers were commemorated on the stamps because of the work they have done. So any idea who is this? 1942 birth centenary of Carl Scheel. So he is the one who discovered lactic acid from sour milk in 1780. Okay. So any idea who is this? Svante Arrhenius. He won a Nobel Prize. So he was the one who got the concept of acid-base measurements. So he's the one who attributed the acidity to hydrogen ions and bases to bicarbonate ions. So thank you very much. So end this with a quote: the most important thing we learn at school is the fact that the most important things can't be learned at school. I think this is applicable to ABG because what you have attended now is a schoolistic sort of a narrative on ABG. But what you need to now do is go look at the ABGs and keep applying all those steps, 6 steps to interpret the ABGs. Then only you would start getting better and better, and try to calculate anion gap, and then apply the concept of gap by looking at change in anion gap divided by change in bicarbonate. So keep doing that, less than 1 or is it more than 1. So then it will keep telling you whether there is a coexisting abnormality that is present. So thank you all.